visible?
Yes, ma'am, it is visible.
Actually, audio is not very clear to me. If anything, please put it in the chat box also.
Sure.
So all the candidates have joined. Can we start the session?
Yes, ma'am. Please go ahead, ma'am.
Okay. So once again, good evening, everyone. So basically, this session is an introduction to pain, and I'll be mostly focusing on a very boring thing, that is the physiology of pain. But however boring it is, we are supposed to know the physiology of pain to understand how our various medications work and how we can make the medications work better. And also just an overview about the management, because in the coming classes, coming sessions, you will be learning more about the details of pain management. So I'll be going through the definition of pain and palliative care, epidemiology of pain, classification, physiology and pathophysiology, and management, just the general principles. So definition of pain, the International Association for the Study of Pain, IASP, put forward a very long definition for pain, that is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. But actually, to understand pain, this long definition is not needed. In simple words, pain is what the patient says hurts. So all of you are oncologists, and I know that you are dealing with patients who have the most difficult pain. So if you can take only one message from this class, that would be this: believe your patient. Pain is what the patient says hurts. Rest everything you can forget. You can even switch off the laptop. But this one particular point, I want everyone to take that pain is what the patient says hurts. So you have to believe your patient. I know that cancer brings about a lot of psychological distress, but don't try to blame the psychological status for the pain. It's because the patient is depressed. It's because the patient is shocked to hear the news. But that is an exclusion. But mostly, we have to believe when the patient says that it hurts. And the concept of total pain, I think the previous session you might have been introduced to that. And being oncologists, you all might be familiar with this. That is, pain means it is not just physical pain, but we have to address the psychological, spiritual, and social aspects also. That is important to improve the quality of life of patient and the family. And what is palliative care? I think this has also been covered, because it's an approach that improves the quality of life of patients and families facing problems with due to life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, or spiritual. And if you look at the epidemiology of pain in cancer, so if you look at the incidence of moderate to severe pain in cancer, this study in 2016, published in 2016, has found out that in stage 4, the incidence of patients with moderate to severe pain is around 45%. Taking all stages together, 50% have, this is not the incidence of pain, this is the incidence of moderate to severe pain. So 50% or more than 50% have moderate to severe pain, and in advanced stages, it comes to around 70%. And if you look at the prevalence of pain in the cancer population, the study again published in 2016, the same study, they found that during cancer treatment, it is around 55%. Even after curative treatment, the prevalence is around 40%. And in advanced or metastatic cancer, it is around 66%. And among this, almost 38% will have moderate to severe pain. And are we treating pain adequately? So this study published in 2018, they found out that when the pain is mild, we are able to give adequate pain relief in 50%. 50%, even with mild pain, they are not getting adequately treated. So if you look at moderate pain, we are giving adequate treatment only to 20% of patients. 80% remain in pain, significant pain. And if you look at severe pain, we are treating only 5% adequately. Almost 95% of the population, they still remain in significant pain. So we are underestimating and undertreating pain. Coming to the classification of pain, I think there is one another session also coming on the classification of pain. So just as an overview, one is acute pain and chronic pain, less than 3 months and more than 3 months. So in cancer population, we will be mostly, it can be acute or chronic also. And another classification is into nociceptive pain, neuropathic pain, and nociplastic pain. So tissue nociceptors are activated, and that causes nociceptive pain. Neuropathic pain is the somatosensory nervous system. Or nociplastic pain is a newer definition. It's a newer definition given to conditions like fibromyalgia, where there is not only fibromyalgia. In cancer population, I can give the example of post-mastectomy pain syndromes. So in which there is a lot of sensitization, peripheral sensitization and central sensitization. So such widespread pain conditions are often referred to as nociplastic pain. And the pain is disproportionate to what we can explain from the pathophysiology. That disproportionate pain, when it happens, it is usually due to pain amplification, and that kind of pain is known as nociplastic pain. Now coming to the acute versus chronic pain. So what is the difference in presentation of this acute versus chronic pain? So 54-year-old gentleman, in case of carcinoma lung with bone mets, he comes with a pathological fracture of right humerus. The patient grimaces in pain, has tachycardia and sweating. He says that he is in severe pain, and it is very sure that we all estimate his pain correctly, and we know that there is a cause for the severe pain, and we often try to treat it adequately. But in the next case scenario, is a 60-year-old gentleman, a case of carcinoma head of the pancreas, on chemotherapy for the past 4 months. Patient says that he is in severe pain. He does not appear to be in distress due to pain. He looks tired and gloomy and has decreased appetite and sleep. So this is basically the difference in pain behavior when it is acute pain and it is chronic pain. The acute pain patient obviously will appear to be in distress due to the pain. The chronic pain patient has also got the same pain score, 10 out of 10, but due to the pain adapting mechanisms in our body, he may not appear to be in that kind of a distress. So this is one reason the oncology residents, our staff nurses, this is a sentence that I think I have heard most in the last 7 years after taking pain management, that madam, that patient says his pain score is 10 out of 10, but he doesn't look like that, or he doesn't appear to be in that kind of a pain. I think some psychological issues there. So this is because there is this pain behavior difference between acute pain and chronic pain. And if you take the non-cancer pain, which I mostly deal with, I often say it's like an invisible illness. Patient comes to you with a lot of pain here, pain there. All the investigations are normal, and we often tend to blame that it's all in your head. At least in cancer population, we know that, okay, there is a cause. Whereas in non-cancer chronic pain, patient comes to you with pain, every investigation is normal. So many physicians tend to they put this blame on the patient's psychological status, telling that it's all in your head. So coming to chronic pain, so it has got an ill-defined onset compared to acute pain and a prolonged fluctuating course. And the overt pain behaviors like grimacing, wincing, and the sympathetic hyperactivity, tachycardia, hypertension, sweating, all these are typically absent. And vegetative signs like lassitude, sleep disturbance, anorexia, all these are present. And patient may not appear to be in pain for you. And only definitive way to determine the presence of pain is to obtain a verbal report from the patient. Ask the patient, what is your pain score? And we must believe that. No matter whether the patient appears to be in pain or not, take a verbal report and we have to document that in our case sheet and treat accordingly. So this should be our motto: believe your patient, treat early and treat well. So coming to the nociceptive versus neuropathic pain. So nociceptive pain is caused by tissue injury. It can be either somatic or visceral pain. Whereas neuropathic pain, here is an injury or dysfunction to the nerve itself. So we should know that in nociceptive pain, this is the character of pain. It is like throbbing, dull aching, catching, etc. Whereas in neuropathic pain, it will be burning, shooting, scalding kind of pain. So why we should know that? Patient says in pain, okay, just pain. We can just go up the analgesic ladder. If the patient was on paracetamol, now change to tramadol, then to morphine. It's not like that. It's very important to take a proper history. And in that, one particular aspect is to differentiate between nociceptive pain and neuropathic pain. Because of this particular aspect. Nociceptive pain, it responds to the traditional analgesics like NSAIDs and opioids. Neuropathic pain, it poorly responds to traditional analgesics. So just for the session to be interactive, I am asking, can anybody tell me which opioids respond well to neuropathic pain? If anyone is already practicing pain along with oncology and they would like to answer, they can answer or put in the chat box. Is morphine a good drug for neuropathic pain? Many of your patients, for example, with bone meds or any, any tumor that is infiltrating or compressing on a nerve, spine meds or anything, they can produce this neuropathic pain, burning, shooting, tingling, numbness, scalding. So we know that it is treated by the anti-neuropathic agents. But when it comes to opioids, the commonly used opioids like morphine, fentanyl, they don't cause significant improvement in neuropathic pain. There are certain other opioids. Yes, I think something has come up in the chat box.
Dr. Mohammed has written tramadol.
Pardon? Tramadol,
Dr.
very good,
Mohammed,
very good. Yes. One is tramadol. Then anything else in the chat box? Yes, that is, yes, excellent. But that is anti-neuropathic medications. We should start on pregabalin, gabapentin, but we should understand that pregabalin or gabapentin don't work overnight. Of course, pregabalin has got a better, faster onset of action. So I personally prefer pregabalin, but again, it will take 3 to 5 days. So coming to opioids, tramadol, tapentadol is one. Anything else?
Dr.
The steroids you can give. I'm asking about opioids. Other than tramadol, tapentadol, any other opioids which are good for neuropathic pain? Okay, I will tell 2 more are there other than tramadol and tapentadol because these 2 are in the same family. So I will take that as one, tramadol, tapentadol, methadone. And another one is buprenorphine. So if your patient is having a more of a neuropathic pain component, it is better to start on these drugs rather than to start with morphine or fentanyl. If they have a combination of nociceptive and neuropathic pain, you can start on morphine or fentanyl, but more dose will be needed to cover the neuropathic pain also. Okay. Now, as I told, I'll go to this very boring session that is a physiology and pathophysiology. But is the physiology of pain important? Whenever I get a chance to take the class on physiology, I show this picture. If you are treating pain or if you are dealing with pain patients, but you don't know the physiology, what is happening, it is just like this 5 blind people, palpating the elephant and feeling the elephant and telling that it's a ball, it's a fan. Each one has got their own perception and they treat accordingly. So we should have at least a basic idea of what the physiology and pathophysiology of pain is about if we are dealing with pain patients and more importantly, if we are trying to treat them. So the pain pathway in the simplest form, it starts from the peripheral nerve. The free nerve endings are known as the nociceptors, the peripheral nociceptors. And the first order neuron is located in the dorsal root ganglion. So this is actually a pseudo-unipolar neuron. It has got two axons. One axon goes to the periphery and forms this nociceptors. The next axon, the central axon, it goes to the spinal cord, the dorsal horn of the spinal cord. And synapses with the situated in the dorsal horn of the spinal cord. And from there, it goes to the cortex. So this is the simplest in which I can explain the pain pathway. But that is not enough, right? Now, so it has got four components, this pain pathway. One is transduction, which happens in the periphery, that a tissue injury occurs, some chemicals are released there. This chemical stimuli is converted to an electrical stimuli, which is known as transduction. And this is then transmitted through the nerve to the dorsal horn and then to the cortex. That is known as transmission. But there is a very, very important step in between, which is modulation. That is, this is not a fixed wired circuit. That is, if 5 number of pain impulse comes from here, it is not that always 5 numbers reach here. The modulation can happen in such a way that if 5 impulses come from here, 10 impulses reach the brain. Or if 5 impulses come from here, only 2 reach the brain. That is a function of modulation of the pathway. And finally, in the cortex, whatever it reaches there, finally, that will be perceived. That is a perception. Okay. Now, so if you look at the pain pathway, so this is the lateral pain pathway. If you go to your first MBBS days, the spinothalamic tract, STT, or the lateral pain pathway. So here, as I told, the peripheral nociceptors are activated. It comes and synapses with the, this is the DRG, dorsal root ganglion, this bulbous thing. And then it comes to the dorsal root, spinal cord, dorsal horn. From there, you can see it crosses to the opposite side and it ascends in this anterolateral fasciculus of spinal cord and it reaches the thalamus. It reaches the thalamus and it then goes to the cortex, sensory cortex, where it is perceived. On the way, it gives some information to the reticular formation, the periaqueductal gray in the midbrain, etc. So this is a lateral pain pathway or the spinothalamic tract. It ends in the ventropostural VPL nucleus of thalamus and from there to the cortex. And this particular pathway is responsible for perceiving the location of pain, nature of pain, and the severity of pain. Now, we have medial pain pathways also. The lateral pain pathway was the spinothalamic tract. We have medial pain pathways like spino-reticular and spinolimbic pathways. So we can see here what is shown in the green. Red is the normal lateral pain pathway, spinothalamic tract. This green is the medial pain pathway, the spino-reticular and spinolimbic. So it gives more information to this reticular formation, pons, midbrain, various areas in pons, midbrain, and medulla. And in thalamus, instead of ventroposterolateral VPL, it terminates in the ventroposteral medial. That is why it's known as a medial pain pathway, VPM, and then reaches the cortex. So why it is important? This medial pain pathway is important. The other pathway deals with the nature of pain, severity of pain, location of pain, whereas medial pain pathway deals with emotions, autonomic responses, and more importantly, what I told, modulation of pain. How the pain gets modulated. Okay. Now, my question is, again, you can put in this chat box, if the stimulus remained constant, the same stimulus is coming from the periphery or the viscera or whatever it is, will the pain remain constant, decrease or increase? What do you think will happen? I have to stimulate our cortex also, otherwise, any answer? If the pain stimulus, yes.
Dr. Debasish has written decrease. Dr. Tejasvi decrease. Dr. Rubar's opinion of the book can happen. Decrease,
So
decrease. Both the answers.
supposedly, yeah, I'm seeing the chat box. So this question is actually that suppose we are not intervening or we are not intervening properly. Then what will happen? The normal physiology, if you look at the normal physiology, for example, if I have a cut in my skin, the normal physiology or pathophysiology is that the cut will heal on its own. And I may have a scar, but ultimately in acute pain, this will heal and I will be pain-free. There will be a scar, that's it. But in chronic pain, if the stimulus remained constant, what is a natural process? That's what I'm asking. If we are intervening, that's a different story. What is a natural physiology and pathophysiology like? If the chronic pain, the stimulus remained constant, would the pain remain constant, decrease or increase over time? In acute pain, mostly it will decrease because it's a natural process of healing. The acute pain is due to this particular cause. In the natural process of healing, it will decrease. But in chronic pain, it will increase. Why? If it is left unattended or we are not intervening adequately, we are trying to brush off the pain and say, okay, it's just psychological, or patient is having some other problems in the family. I just diagnosed the malignancy just a week back. Why should I start the patient on opioids? The pain is disproportionate. Maybe it's just that, the patient can't just accept the news. That is why he's having disproportionate pain. So if we brush off like that, what is a natural pathology? The pain will increase. And why? What in the pain pathway leads to that increase? That's my question. I have already told that during the pain pathway. Yes, modulation. And more specifically, what kind of modulation? I'll tell in the next slide. Yes. Modulation of pain can be of two types. One is excitatory modulation, and the most important word in this class after the first sentence that you should believe your patient, the most important point is this word, sensitization. So excitatory modulation or sensitization, if it happens, the pain pathway is amplified some 100 times, and to that extent that even touch hurts. And the another one is inhibitory modulation. If we are treating early and if we are treating well and if we are intervening adequately, the inhibitory modulation takes out and the patient says that, over time my pain is much better now. So again, this is very tough and very boring, but I need to tell you what happens in the event of sensitization to know that which drugs acts in this or can modulate the pain pathway. So if you look at excitatory modulation or sensitization, there are two types. One is peripheral sensitization and the other one is central sensitization. So this is a periphery. Okay. This is our nerve. This is a nerve. This is a nociceptor. Suppose there is a tissue injury. This is a tissue injury. What happens? So many inflammatory cells are attracted due to, the vascular plasma extravasation and many other tissue distortion and disruption and all. What happens is mast cells, neutrophils, all these are attracted to the tissue injury site. And they release the substances like histamine, prostaglandin, bradykinin, all these inflammatory mediators. And these mediators, they act on various receptors in this afferent nerve ending and they activate this nociceptors. So more tissue injury means more mast cells, neutrophils are activated, more inflammatory mediators are released. This is known as inflammatory soup. All this bradykinin, prostaglandin, histamine together, this is known as inflammatory soup. So this inflammatory soup, it goes on activating this nociceptors, and the net result is that this primary afferent neuron, it becomes hyper-excitable. Hyper-excitable in the sense that lower threshold for stimulation. Earlier, only if a strength of a force of For example, a force of 10 newtons was needed to activate the, just example, it's not Newton there, but the force of 10 Newton was needed to activate the receptor. But now even a force of 5 Newton can activate the receptor. So lower threshold for stimulation. Then more nociceptors. The nearby sleeping nociceptors are now recruited. And increased response to a given stimulus. Not only that they respond to a lower stimulus, for any given stimulus, there will be more response, increased response. And spontaneous activity, even if there is no stimulus, especially in cases of nerve injury, even if there is no stimulus, they will transmit the impulse to the spinal cord. So all these will lead to this hyperexcitable state in the periphery, where exactly the pathophysiology is, injury or malignancy, whatever it is, that leads to this peripheral sensitization, leads to something known as primary hyperalgesia. Primary hyperalgesia means an exaggerated response to a nauseous stimuli. Okay. Now, so how we can intervene? So here we have the prostaglandin. So to inhibit the prostaglandin production, which drug we can give? Here, how can we target the prostaglandins? Anything in the chat box? To decrease peripheral sensitization, correct. NSAIDs. So NSAIDs decrease peripheral sensitization by inhibiting the production of prostaglandins. So COX-2, COX-1 or COX-2, whatever it is, cyclooxygenase enzyme. So that is a role of NSAIDs in cancer pain or any pain. A short course may be useful by decreasing the peripheral sensitization. Second, just a minute. Here, the neurotransmitter release or the conduction. I think this is conduction. Which drug can actually block the conduction through the nerve? We have to block the conduction through the nerve. How will we block the conduction through the nerve? No, gabapentin does not act in the periphery. It is local anesthetics. This is how our nerve blocks work in the periphery. Okay, to conduct, it blocks the conduction through the nerve by sodium channel blocking. So NSAIDs and local anesthetics have role in the peripheral sensitization, in decreasing peripheral sensitization. Next, so now we come to the central sensitization. This happens in the dorsal horn of the spinal cord. Okay, so this is a primary afferent neuron, the neuron which is carrying the pain impulse from the periphery. And here, this is the dorsal horn. So here we have receptors like AMPA. This is AMPA, NMDA, NK1. So many receptors are here. And this one is a voltage sensitive calcium channel. So what happens is, normally when they release the neurotransmitters like glutamine, it acts on this glutamate, it acts on AMPA, this blue one. This is normally this acts on AMPA and causes a current, produces a current that which is transmitted to the brain. Now, in case of prolonged activation from the periphery, that is, peripheral sensitization has happened, we have not treated adequately at that point of stage. So many impulses, abnormal traffic, heavily abnormal traffic is coming from the periphery. Now what happens is, this receptor which was sleeping will become active. This is our notorious NMDA receptor, the culprit, the main culprit behind the central sensitization. So earlier only the AMPA was active. Now this NMDA will become active. And once NMDA gets activated, I will tell you what happens in central sensitization. It is amplified. More current will pass to the will be transmitted to the brain. And here you can see this voltage sensitive calcium channels. So, okay. So this calcium, when it enters this voltage sensitive calcium channels, it causes a release of neurotransmitters. These are the neurotransmitters. Okay. So this calcium. Here, I will tell with the help of the diagram. So first, how will we block this NMDA? So we are going to, I told this is the main culprit behind central sensitization. So how can we block this NMDA? Any answers? Any NMDA antagonist that you know? One opioid is there which has got action on NMDA. Correct, methadone. So that is true. Yeah, so many people have come up with the answer. Very good. So methadone has got action on NMDA. Any other NMDA antagonist that you know of? There is one drug. Yeah, ketamine. Very good. Ketamine. So ketamine, methadone, even magnesium, all these are NMDA antagonists. So that is the role of NMDA antagonist. Okay. Second one, this calcium. This is what I was trying to explain before. So calcium, when it enters through the voltage sensitive calcium channel, it causes a release of more neurotransmitters from the primary afferent neuron. So which drug blocks this voltage sensitive calcium channel? Somebody has told the answer before in the previous slide for peripheral sensitization. Then I told that that drug does not act in the periphery, it acts centrally. Which drug acts in the voltage sensitive calcium channel and decreases the release of neurotransmitters? Correct. Gabapentin. The gabapentinoids, they act on the voltage sensitive calcium channels and inhibits the release of neurotransmitters. That is why gabapentinoids, they have a role in desensitization. So in cancer pain, in cancer pain, there is a role in prescribing gabapentinoids. Okay, it's not just for neuropathic pain. You can prescribe gabapentinoids even for this purpose, to decrease the sensitization, and I regularly do that to my fibromyalgia patients, any pain amplification, chronic pain after surgery, cancer pain with a lot of sensitization, I do prescribe gabapentinoids. Then next is here. Again, which I have already told, the drug that blocks the conduction. So whatever happened has happened. Now NMDA, AMPA, everything is producing that current. How will you block that conduction of that current or that stimuli? That is through sodium channel blockers like lignocaine, and oxcarbazepine is also sodium channel blocker. The next one is here. Because here also, COX-2 has got a role. When excess calcium is produced, it causes phosphorylation of the cyclooxygenase enzyme, and prostaglandins are produced, and that prostaglandins also act on the various receptors, causing increased release of neurotransmitters. So here also our NSAIDs has got a role in preventing or decreasing the excitatory modulation or sensitization. So these are the drugs that act on the sensitization, excitatory modulation or central sensitization. So this you don't need not know other mechanisms. So this is a summary. When there is central sensitization, whatever I have told before, that is NMDA has started activated. NMDA has started acting. The voltage sensitive calcium channel is intake. They have intake of more calcium. So the net response is like this. In the dorsal horn of the spinal cord, these neurons are known as projection neurons. The second order neurons in the dorsal cord. I told that the primary first order neuron is in the dorsal root ganglion, DRG. The second order neuron in the spinal cord, dorsal horn, they are known as the projection neurons. Now, they also have got increased responsiveness. That is, to a lower threshold itself, they will show an exaggerated response. And more second order neurons are recruited, and they increases the receptive field of projection neurons. Receptive field that, for example, earlier the injury, in terms of injury, it will be able to understand more. The C6 was the dermatome in which there was injury, my thumb or something like that. So initially, the afferent neurons from the C6 will activate the corresponding second order neurons in the dorsal horn, and the patient will feel pain in the C6. But in the event of central sensitization, what happens is the afferent neurons coming from the C7 dermatome, they also through interneurons cause activation of the C6 projection neurons. So the net result is that I will feel that my pain is not just coming from the C6, the C7 dermatome, C8 dermatome also, I will feel that pain is there. Or you can, in simple terms, you can see that the area of pain increases. You might have noticed in your practice also that the patient initially complains of back pain in one small area, but after some time, as a result of sensitization, they will say that my whole back is painful. So that receptive field increase is also a result of this central sensitization. Another thing that is happening in the dorsal horn is synaptic reorganization of A beta fibers. Normally, A beta fibers, they respond to touch, and C and A delta fibers carry pain. But in case of the synaptic reorganization within the dorsal horn, even the A beta fibers, when activated, causes activation of this A delta and C, not A delta and C fibers, the corresponding projection neurons. It will be too complicated to understand, but the result of this synaptic reorganization is that, which I showed in the previous slide, even touch becomes painful because A beta fibers normally carry touch. So after this synaptic reorganization, even touch becomes painful. So I have seen my staff nurse, when I ask them, Sister Ji, or that is how we call here, how is the pain? How is the patient's pain? They tell that, ma'am, I just when I touch the painful area and the patient is screaming in pain. That means it has to be psychological. It is not psychology of the patient that has to be blamed. It is the ignorance of the staff that has to be blamed. Because once the sensitization sets it, peripheral and central sensitization, all these things happens. Primary hyperalgesia, secondary hyperalgesia, and allodynia. Allodynia means even touch becomes painful. Non-nauseous stimuli, also the patient will feel pain. That is due to the synaptic reorganization. So, and once all these things sets in, that is primary hyperalgesia, secondary hyperalgesia, allodynia, then the pain becomes extremely challenging to treat. So this central sensitization is known as neuroplasticity or wind-up phenomenon, another word for that. So this is a net result, the amplification of the pain pathway from the periphery as well as the central dorsal horn if the pain is left unattended. So with time, the previous question, the answer is with time. I asked you, with time, what will happen if the impulse remain constant? Even if the impulse remain constant, with time, the area as well as the intensity of pain increases, even touch becomes painful and the pain becomes extremely challenging to treat. So I think I didn't tell secondary hyperalgesia. Primary hyperalgesia means it is exaggerated response to a nauseous stimuli in the painful side. For example, in terms of injury, if the injury is in the C6 dermatome and for a given nauseous stimuli in the C6 dermatome, the patient is experiencing more pain. That is primary hyperalgesia. So what is secondary hyperalgesia? What is secondary hyperalgesia? Any answers in the chat box? Any answers? Okay. It means, which I have told, because of the receptive field is increasing, even if I give a nauseous stimuli in a C7 dermatome, my injury is in the C6 dermatome, but even if I give a noxious stimuli in the C7 dermatome, there will be an exaggerated response. So that is a secondary hyperalgesia. Somebody has answered correctly. And allodynia means even touch becomes painful. That is non-nauseous stimuli also, now there is pain. Okay. And about inhibitory modulation. So there is this excitatory modulation. There is something known as inhibitory modulation also. So if you look here, the most important structures that contribute to the inhibitory modulation is this star, periaqueductal gray in the midbrain. Also, we have the locus ceruleus in the pons. Also, we have the rostroventral medulla. So, all these structures, they give there's an inhibitory pathway coming from that. And then they act on the dorsal horn receptors, the dorsal horn neurons. And when this pathway is activated, or when this pathway is more active, it causes inhibitory modulation. That is, with time, the pain becomes less. So, which is an important neurotransmitter and receptor in this pathway? How we can manage this inhibitory modulation? This is basically the neurotransmitter involved is noradrenaline, and the receptor involved is alpha-2 adrenergic receptors. So, the alpha-2 agonists like clonidine, noradrenaline or norepinephrine reuptake inhibitors like tricyclic antidepressants, SNRIs like duloxetine, amitriptyline, even TCS like amitriptyline, SNRIs like duloxetine, venlafaxine, all these drugs, they will when noradrenaline is released here, it inhibits a reuptake of noradrenaline. So more noradrenaline will be available to act on the alpha-2 receptors, and that activates the inhibitory pathway. Can you tell any opioid which has got this function, that is reuptake? There are actually two opioids that reuptakes inhibition of noradrenaline. Any opioids? We know that tricyclic antidepressants are there, SNRIs are there, but any opioids with this action, inhibition of noradrenaline reuptake? Any answers in the chat box? Any opioids? Buprenorphine, no. Buprenorphine, no. Any other? Correct, tramadol. That is very good. Another one more is there. It has to be methadone, because no other opioids get this kind of variety in that action. Methadone has action on almost everything that modulates the pain pathway. It has got action on NMDA. It has got action on this reuptake inhibition of noradrenaline, and so many other actions are there. But most importantly, it is tramadol, tapentadol. Okay, these two have very important, very significant action on this noradrenaline reuptake inhibition. So in that path, in that manner, this tramadol has got an important role in inhibitory modulation. But other opioid receptors, they also have a role in inhibitory modulation, because some supraspinal pathways, there are opioid receptors are there. For example, in periaqueductal gray, opioid receptors are there. So other opioids also help in inhibitory modulation. But this particular very important pathway from periaqueductal gray, locus ceruleus, that is mediated through noradrenaline. So these drugs help there. Okay. So our aim should be to intervene early, that is before the sensitization sets in, and or recognize and target if it has already set in. So it has to be a team effort. If you have to tackle the pain in which already sensitization has set in and it has become extremely challenging to treat, then definitely it has to be a team effort. Now, the last part is just one slide. I will say the management of pain general principles. So the pain has to be managed by a multimodal and multidisciplinary approach. So I would say the 4-step approach. In the first step, we have to correct the correctable. For example, a few years back, one patient was referred to Pallium India due to intractable abdominal pain. So from a tertiary care hospital. So the patient was given morphine and paracetamol, tramadol, whatever they have, the patient was given that, and there was no relief to the abdominal discomfort. This is a story I heard from Rajagopal sir. So actually, the reason for that abdominal pain was not pancreatic malignancy. The patient had pancreatic malignancy, but it was just constipation. Just that the patient was very severe, the patient was in distress. So just that they didn't appreciate that. They didn't correct the correctable. So Whatever be the malignancy, whatever be the cause, we should always try to see whether there are any correctable factors. When the patient says abdominal pain, oh, he is having pancreatic malignancy, abdominal pain is expected. So that should not be our approach. So we should give attention to detail and try to find out, is there any correctable factors. And then we have non-pharmacological measures like physiotherapy, psychotherapy to address all the components of total pain. Then we have pharmacological measures that we should, according to whether it is nociceptive pain or neuropathic pain, we will manage. Then we have interventions, either percutaneous interventions or surgical interventions. Now, for nociceptive pain management, this is a WHO analgesic ladder. You all are familiar with that. Step 1, non-opioids plus or minus adjuvants. Step 2, weak opioids plus step 1. Step 3 means strong opioids plus step 1. Now, later on, WHO added a 4th step. If the pain is refractory to these 3 steps, we can go for invasive and minimally invasive treatments, that is interventions. But in today's current scenario, this need not be like this. The patient, it's not necessary we try all these 3 steps before going on to intervention. Early intervention can also bring a lot of difference to the patient's quality of life, the compatibility with the complaints with the treatment and all. Now, this is a neuropathic pain ladder. The other one was basically for, of course, adjuvants are for neuropathic pain, but there is something known as neuropathic pain ladder, in which we say that the first line, that is 4 to 6 weeks, because these drugs will not work overnight, we should give a trial of either gabapentinoids, SNRIs, TCS, tricyclic antidepressants, and topical. This is not important in cancer population. Post-herpetic neuralgia and all, we can give this topical. Of course, your immunosuppressed patients, they can come with PHN or herpetic neuralgia. There we can go for topical. Otherwise, gabapentinoids, SNRIs, or TCS. These are the first-line drugs, either one of them. The first line. Second line, we combine any 2 of this first-line drugs. Tramadol, they say us second line, but I give us first line for neuropathic pain, because these drugs will take time for action. Then third line, we have the SSRIs, selective serotonin reuptake inhibitors like sertraline, other anticonvulsants like armoxapine, NMDA antagonist ketamine, interventions like sympathetic blocks, etc. Fourth line, we have neuromodulation. And fifth line, remember, fifth line is the low-dose opioid trial. So if your patient is having predominantly neuropathic pain, don't jump into a strong opioid. You can start with tramadol and any of these drugs. I think in the classes sessions which are coming next, you will be taught like which drug to start for which patient. Otherwise, you can ask me, I can also tell at the end. Then sixth line is a targeted drug delivery using intrathecal pumps, etc. Seconotide, baclofen, all these intrathecal pumps are available. Baclofen is, of course, toxicity. Seconotide is useful for neuropathic pain. And finally, coming to the interventional pain management, for upper abdominal malignancies, we have celiac plexus neuralisis, very good evidence. So your pancreatic and upper abdominal malignancies like liver up to the middle of transverse colon, you can refer the patient actually early for the celiac plexus neuralisis, because it was a very good evidence. Among all these interventions, maximum evidence is for celiac plexus. And it not only reduces pain, it reduces the nausea, vomiting, and the complaints with treatment will be more. And the lower abdominal and pelvic malignancies, we go for superior hypogastric plexus neuralisis. And perineal or anorectal malignancies, we go for ganglion-lumbar neuralisis. And for metastatic vertebral fractures or metastatic lesions, we can go for vertebroplasty or kyphoplasty. So as I have shown here, as I have told before, the celiac plexus or splanchnic block, both are same actually, has got the maximum evidence. Sorry, celiac 2A plus and splanchnic is the same thing done a little above. It's 2B plus. Okay. Now, what are the barriers to pain relief? So, one barrier to pain relief is the attitude towards pain. Especially in our population, I have seen that the attitude is that it's after all pain. You can bear it, right? So, I don't think that is there in the Western population. But more in our population, I mean, the Indian scenario, or what I have seen is the attitude towards pain means you can bear it. And second thing is underestimation of pain. I don't know how many of the oncology or even pain physicians or palliative care physicians, they actually ask the pain score and document it. Unless you ask the pain score and document it in your case sheet, you're actually underestimating. If you're just looking at the patient's pain and prescribing drugs, you are prone to, underestimating and undertreating the patient's pain. Third is the misconceptions about painkillers. Okay, I remember a consultant telling me, don't give paracetamol, it will cause, he referred the patient to me, but he was telling me, don't give paracetamol, it will cause liver problem, and don't give NSAID, it will cause kidney issues, don't give opioids, it will cause sedation. And I was wondering why he referred the patient to me. Okay, so the misconceptions about the painkillers, especially the fear of opioids, the opiophobia. I can remember one patient admitted in the internal medicine department in one of the hospitals I know, and the patient happened to be my relative. So she was on, I had started her on 5 mg morphine 4th hourly and 10 milligram HS. So anyone who has read about morphine knows that this is a starting dose of morphine. This 5 mg 4th hourly and 10 mg HS is a starting dose for adult. So when I went to that hospital, this morphine was stopped, and I told the doctor there, doctor, why did you stop? The patient is in severe pain. So he was telling me, Vineetha, the patient is such a high dose, patient is taking such a high dose of morphine. How can you give that high dose of morphine? So I politely said, sir, this is a starting dose of morphine. Kindly give her. She cannot suffer. The patient's son has already told. It's like what our priority is, the patient should not suffer. So the opiophobia is a very, very important problem among our various specialists. So, and another problem these studies, they have found out that how much we underestimate pain. How much we underestimate pain. When patients rate their pain as moderate to severe, the oncology fellows fail to appreciate the severity in 73% of cases. So, and the discrepancy between patient and physician evaluation of severity is a major factor in inadequate relief, or it's a major barrier to pain relief. And when the patient had pain scores of more than 7, in almost 25% of patients, pain was underestimated, especially in female patients. So I always tell this in my clinic, that in my hospital, because I work in a tertiary care referral center. So if the patient has tachycardia, immediately RRT, rapid response team, will be announced. If the patient has a urinary retention, immediately again the urologist will be called. But such an urgency is not seen towards pain management. Why? If the patient has dyspnea, again rapid response team is announced. Patient has tachycardia, RRT is announced. If the patient has got bradycardia or cardiac arrest, then code blue is announced. But nothing is announced. No urgency is seen. If the patient says that I'm having pain, the sister will go and ask the duty doctor. They will say give paracetamol over 15 minutes or tramadol over 15-20 minutes. Tramadol will be given over 1 hour time. Then they will reassess the patient's pain. Then the patient will say that my pain is not still adequately controlled. Again, they will call the duty doctor. Then they will say another drug that will be given slowly. So no, I don't see any urgency in managing pain. So this is because nobody dies due to pain. Nobody, unless like bradycardia, tachycardia, or dyspnea, nobody dies due to pain. But what we don't understand is that many people die in pain, and more importantly, many people, they live in pain. So what is important is an early referral. So how we can estimate and treat the pain adequately? We need to do an early referral to our pain services, and there should be pain and palliative care, an early referral and continuum of palliative care. To conclude, this Declaration of Montreal, which was passed in which was passed in the IASP 2010 International Summit. They said that they concluded that the access to pain management is a fundamental human right. So, pain management is a basic human right, and pain is what the patient says hurts, or when he or she says it does, we have to believe the patient regarding his or her pain. So, thank you for your patient listening. If any questions, you can ask or put in the chat box. Thank you.
Thank you, ma'am. Thank you for the wonderful presentation. Participants, if you have any queries, and you can ask, unmute yourself, or you can put it in the chat box.
Thank you, Dr. Vineetha, for that excellent, very informative talk. Especially like the message, you should believe your patient. You should believe your patient and assess the pain properly. Regarding the pain pathways, mechanism, everything was in a nutshell. Very informative one. Are there any doubts? You can unmute and ask or either put in the chat box.
Any difference in tremorol? No, actually not much difference in mechanism of action, but it is tepanerol is said to be better tolerated. In my hospital, I don't have tepanerol, so I prescribe only tremorol. But the gastrointestinal GI side effect profile is better for tepanerol. Mechanism of action is almost the same. Nausea, vomiting is less with tepanerol. ER preparations, what about ER preparations means? Can you, what about ER preparations? Can you please
Dr. Mohammed Shafib, can you please elaborate the questions, what you mean by the about AR preparation, so that faculty can answer accordingly?
Am I audible?
Yes, Doctor, you are.
I'm asking about what about the dose difference while we using ER and immediate release tapenol preparations? How can?
I'm sorry, the faculties and facilitator both have lost their connections. We will wait for 1 minute. Thank you, Doctor, for replying.
Can you please put in the chat box, because some problem is there in my audio. I'm not able to hear. But one question that was asked was this one, tramadol and morphine. So I don't give tramadol and morphine together, but in certain situations I give two opioids together. One is when we start on methadone, and another thing is methadone. It will take time to act the plasma levels to attain the steady state concentration. So while the patient is being initiated on methadone, for immediate action, the patient can be continued on morphine. Other than that, also like patches, maybe buprenorphine patch. This patch also takes time for action. Penta patch takes around 12 hours. Buprenorphine patch can take 24 to 36 hours for the onset of action. To bridge that gap, we can give tramadol or morphine immediate release. Other than in these situations, I don't usually club opioids. I just optimize a dose or go for a opioid switching or opioid rotation.
Thank you, ma'am. And Dr. Mohammed Shafi has also asked, what about the ER preparations? Sir, could you please elaborate? So now the faculty has joined.
Can you put in the box because my audio is not clear? What was the question?
It was about the dose adjustment in tapentadol ER preparation.
Yeah, I think you can put in the chat box once, just in short, because my audio is having some problem. I'm not able to hear clearly. Any other questions also we can put in the chat box. But otherwise also the next sessions will be more on the pharmacological management, so it will be covered. Dose adjustment in tapentadol ER preparation. So dose adjustment in duration of tramadol infusion. Dose adjustment, I didn't understand that because it's like mostly given ER preparations are given OD or BD. And I don't have experience in prescribing them because I don't have access to tapentadol. But what I have read is 50 milligram, start with 50 milligram OD or increase to 50 milligram BD. Extended release means we can give us OD or BD. That I don't have much, even 100 milligram is a 100 milligram ER preparation OD or BD. But I don't have much expertise with tapentadol. Duration of tramadol infusion 15 to 20 minutes. I always give it over 15-20 minutes. If it is like older patients, I may actually give it over 20 to 30 minutes, like over 70 years or something. But otherwise 15-20 minutes. And one more thing I'll tell because maybe it will be covered in the... Yes, correct. 50 milligram ER and starting BD and later hiking. And one more thing about buprenorphine I need to tell because a lot of oncologists that I know, as well as a lot of other physicians, surgeons, they have this, I don't know for what reason, that inking towards buprenorphine. They think that buprenorphine has got a better side effect profile and it will not cause sedation, respiratory depression like fentanyl and morphine. But I will tell you, buprenorphine is a wonderful drug if you use it correctly. Correctly means for the correct indication. In my practice, because I deal with a lot of non-cancer pain, I use buprenorphine for neuropathic pain conditions like diabetic neuropathy, trigeminal neuralgia, radiculopathy. For all this, or even cancer pain with a neuropathic pain component, buprenorphine works wonderfully. But for nociceptive pain, buprenorphine, I have found it to be a very less effective agent compared to morphine or fentanyl. So I have seen even palliative care physicians or oncologists or many specialties just prescribing buprenorphine like that. And when the patient comes back with saying that I'm having pain, we're already having a 10 microgram or patch. It is supposed to work. It will not work that way. And another important thing is, once that buprenorphine patch is applied, this buprenorphine has got a very strong affinity to the mu opioid receptor. Now, if you give tramadol as a PRN dose, if you give tramadol or morphine also, they cannot, remove the buprenorphine from the mu receptor. Buprenorphine has got this, it very binds very strongly to the mu receptor. So, in effect, what happens is your PRN dose of morphine and tramadol also will not work. Fentanyl also will not work when the buprenorphine is there. So, what I do is I first remove the patch. I basically I don't like at all when patch is applied for wrong reasons. I remove the patch and start the patient on morphine. Usually the patient will get absolute, very good relief. So this morphine phobia has led to the indiscriminate use of patches, especially buprenorphine patch. But I have not found it to be effective in nociceptive pain much when compared to neuropathic pain. So you have to use it intelligently. How to withdraw opioids is beyond the scope of this class. I think that will be taken in another, because if you ask me, we reduce by 30% over 3 to 5 days and slowly withdraw. But That is another entire session in itself. After long term, for example, if your patient is on like 1 year, then we reduce 30% in like 2 weeks or 1 month time, and then we slowly taper it off. Buprenorphine sublingual tab. I don't have any experience with buprenorphine sublingual tab, but with buprenorphine patches, I would say that one is that it takes a lot of time for action, 24 to 36 hours for optimal action. And I have found out in my experience, buprenorphine is more effective for neuropathic pain than nociceptive pain. And there is a reason also. If you Google it, you will find why buprenorphine is more effective for neuropathic pain. That is beyond the scope of this class discussion, but there is a reason. And it works very well in neuropathic pain conditions. Where morphine, fentanyl, everything fails, buprenorphine will work. So that is why in my hospital, many patients were referred to me for like this diabetic neuropathy or some other neuropathic pain. I applied buprenorphine patch and the patients had excellent relief. And then my surgeons and physicians, they started applying this patch for anything and everything. And then they told me, Vineetha, when you applied, there was excellent relief. When we applied the same patch, there was no relief. Why is it like that? I told sir, it is the same patch, but you should be knowing to select the patients well. Patient selection is important. So buprenorphine sublingual tab, definitely it will work faster, but I don't have any experience with that. And something, buprenorphine patch, the cost is around 1,100, 1,200 for one patch. Fentanyl patch is also around 750. So recently I saw a patient who was seen by palliative care physician outside, and she has 20 microgram per hour patch. One patch on this chest, another buprenorphine on this chest. Patient was wincing in pain. Then the reason why the physician started on buprenorphine was patient had a phobia for morphine. When we say the name morphine, the patient is, I don't want that. So what I did is, I sat with the patient and I explained, see, morphine and buprenorphine is like brother and sister. They belong to the same family. They have same side effect profile. There is nothing to fear about morphine. And this buprenorphine will, lead you to financial crisis. You are already in a lot of debt due to the cancer treatment. This patch will only add to that. So we will at least give a trial of morphine. The patient agreed. And this patient who was on 20 microgram per hour of buprenorphine, that is 20 microgram per hour means 2,500 per application. That patient got excellent relief with 5 mg morphine, which costs just 5 rupees. So indiscriminate uses of patches is what is happening in our oncology patients right now. So kindly avoid that. Morphine is a miracle drug. It's a wonder drug. It is cheap. Use it correctly. Nothing will happen. In the safe hands, morphine is the safest drug possible. Don't go for this patches unless indicated.
Are there any more questions? Or can we wind up the session? Ma'am, there are no more questions in the chat box. No one else is raising hands. So that was a very excellent presentation, the basics, especially the part. Everything very in a crispy way. Okay, ma'am. Thank you so much, ma'am, for the presentation. So we wind up the session, and any inputs from the silent side again?
Yes, thank you, Dr. Vineetha Gopal, for the wonderful presentation. That was very much wonderful. Thank you, Dr. Manu John, for facilitating the entire sessions. Thank you, participants, for
Thank you, everyone.
joining and putting out your insights. Thank you. Let's see you in the next sessions. Bye.
Thank you. Good night.
Thank you.